Assalamu alaikum wa rahmatullahi wa barakatuh, and good evening, everyone. My name is Dr. Ayman Abdelhadi. I am a consultant adult cardiologist at Riyadh Care Hospital in Riyadh, Saudi Arabia, and the head of internal medicine department at the same hospital. I am also an associate professor of cardiology at Ain Shams University, Cairo, Egypt. It gives me great honor to be among a distinguished group of speakers and consultants that will carry on this scientific program sponsored by Merck regarding diabetes mellitus and its relation to cardiovascular disease. Now, the first presentation today will be about diabetes management in the era of cardiovascular outcome trials, and I will kick off with a case presentation. This is a 35-year-old white sedentary female with history of chest pain few minutes during her daily exercise activity in order to reduce her body weight. When she went to the emergency room, she received sublingual Izordil or nitrates, and her chest pain subsided. While asking the patient, she was complaining of excessive micturition, especially at night with excessive thirst. And her lab tests requested included fasting, postprandial blood sugar, and hemoglobin A1C. She attended the clinic to review the lab results and receive comprehensive medical care. Her body weight and exercise regimens were among her concerns as well. Her past medical history, there are no positive findings in her past medical history, but her family history is positive for uncontrolled type 2 diabetes mellitus, and the father was receiving insulin. Furthermore, the father was admitted to a CCU a few years ago and because of a heart attack, and he died at the age of 65. At the clinic, her clinical examination revealed a body mass index of 34 kilograms per square meters. Her waist to hip ratio was 1.1. Her abdominal examination was revealed a lax abdomen with no tenderness. Her chest was clear to auscultation, and cardiac examination revealed normal heart sounds with no abnormal sounds. Neurological examination revealed decreased sensation to pain, touch, and temperature in both lower limbs, with impaired vibration sense, proprioceptive sensations, and reduced ankle reflexes. Her blood pressure was 140/94, with a heart rate of 75 beats per minute, regular. Now, the lab results revealed a fasting plasma glucose of 230 milligrams per deciliter, a postprandial blood sugar of 343 milligrams per deciliter, and her hemoglobin A1C was sitting at 8.9%. Her eGFR was 78 ml per minute per 1.73 square meters. Thus, in accordance with the ADA diagnostic criteria, type 2 diabetes was diagnosed. The patient states that I want to avoid injectable therapy due to my busy lifestyle, and also it scares me to think about becoming like my father. Now, there is a strong association between diabetes and cardiovascular disease. Complications of diabetes include a 65% of deaths are due to cardiovascular disease among diabetic patients. The stroke risk is higher by 2 to 4 folds, heart rate is higher by 2 to 5 folds, and coronary artery disease is higher by 2 to 4 folds compared to non-diabetic population. So in order to choose a good anti-diabetic drug, the ideal diabetic drug should have a flat profile of glycemia, should be able to reduce hemoglobin A1C, should prevent major glucose excursions, should be weight neutral, if not reducing if the patient is biochemically neutral, especially to lipids and kidney functions, and favorable long-term effect on micro and macrovascular complications of diabetes, if possible. And of course, it shouldn't have any adverse cardiovascular effects. So the first thing to decide is what is the ideal hemoglobin A1C for this patient. Now, I will leave this to the experts in the following lectures. However, I just wanted to share with you how to choose or how to decide upon the most suitable hemoglobin A1C for the patient, depending on certain criteria such as hypoglycemia, disease duration, life expectancy, important comorbidities, established vascular complication, patient attitude and expectations, and resources and support systems. And all the societies for diabetes, they all recommend that the first line for glucose lowering should be lifestyle modification coupled with metformin. So metformin was and is still the first line of therapy for recently diagnosed diabetic patients, along with lifestyle modification. When choosing metformin, you have to decide two things. What is the dose you are going to use, and why are you using metformin? So we started by prescribing metformin extended release, considered to be the preferred drug, of course, to initiate for this patient. But what should be the dose? Should it be the 1,000 milligram per day extended release, the 2,000 milligram per day extended release, or more? Well, when you look at the evidence, you find that metformin is recommended for all type of patients, and it is the mainstay of therapy for patients who are recently diagnosed with diabetes mellitus. The dose range is 1,000 to 3,000, as all of you know, but there are certain points to be taken into consideration, and the most important among them is the renal functions. So depending on the eGFR, you decide upon the dose of your metformin, and below 30 mils per minute, metformin is usually contraindicated. Metformin has a dose response, so that is why as you increase the dose of metformin, you reach the maximum benefit at the 2,000 milligram per day of metformin. This gives you the best decrease in hemoglobin A1C. As the dose increases, you will not gain more, but actually you may gain less. And that is why we try to avoid higher doses than 2,000 milligrams per day of metformin. So again, metformin is the first line of therapy, but when it comes to cardiovascular protection, as we mentioned earlier, one of the criteria that it's preferable if the medicine has cardiovascular protection. Well, we have contradicting evidence from the US and the EU, which is Europe. In the States, they state that there are no clinical studies establishing conclusive evidence of macrovascular risk reduction with metformin or any other anti-diabetic medication. But the European says that based on the UK PDS analysis from 342 overweight patients treated with metformin after failure of diet alone, metformin significantly reduced any diabetic-related complication, mortality, and risk of MI versus diet alone after 10.7 years. And this diagram tells you that those patients who received metformin compared to those who received intensive therapy, compared to those who received conventional therapy, there was a relative risk reduction of MI of about 39% for those who received metformin compared to intensive therapy without metformin and compared to conventional therapy. Moreover, this reduction in MI, this significant reduction in the incidence of MI was maintained over a 10-year follow-up, as you see here. What about weight reduction? We know that metformin is one of the medications that can really help in weight reduction. And compared to other types of metformin, which is a combination with sulfonylurea or TZDs or sulfonylurea and TZDs alone, we find that the weight reduction is more significant with metformin alone compared to any other combination or TZDs and sulfonylureas alone. So we decided to continue the metformin at 2,000 milligrams per day. The patient has no more chest pain, no abdominal discomfort, but her hemoglobin A1C was still high at 8.4. So what should be the next step? Definitely, you need to, first of all, emphasize on the lifestyle modification, and then, according to guidelines and common sense as well, you need to add something else. So if you are going to add another glucose-lowering drug, which one will be your choice? Will it be SGLT2 inhibitors? Will it be TZDs? DPP4 inhibitors? Or sulfonylurea? Well, according to the guidelines, as mentioned earlier, the American Diabetes Association, in their guidelines, in the algorithm, as you see here, that the second step in the management after lifestyle management and metformin is an additional agent. And based on the cardiovascular profile in terms of mortality and cardiovascular risk factors, you decide which agent to use. Let's start by the first group, which is the SGLT2 inhibitors. Well, we know that this group of medication, they increase the renal glucose excretion independent of beta cell function, and thus they carry very low risk of hypoglycemia. They reduce the hemoglobin A1C modestly by 0.5 to 0.7% compared to placebo, and they also promote weight loss of about 2 to 3 kilograms over 12 weeks of studies. What about the next group, which is the DPP4 inhibitors and the GLP-1 analogs? Well, the DPP4 inhibitors were shown in the EMPA-REG outcome trial to reduce cardiovascular death, to reduce hospitalization for heart failure. And in the canvas, it was also shown that the SGLT2 inhibitors can reduce the primary outcome, which is cardiovascular death, non-fatal MI, and non-fatal stroke, and hospitalization for heart failure as well. Well, regarding the GLP-1 analogs, which are injectables mostly, they reduce also the outcomes, the primary outcomes, which are cardiovascular death, non-fatal MI, non-fatal stroke, and they have also a favorable effect, as you see here, on non-fatal strokes and cardiovascular death. This is one of the latest trials that was published about 2 years back. It's called the DECLARE-TIMI 54 on dapagliflozin, which is one of the members of the SGLT2 inhibitors. And you can clearly here see that it significantly lowered cardiovascular death and hospitalization for heart failure compared to placebo. So, since the patient was having chest pain and she is at high risk for cardiovascular or at high cardiovascular risk, we decided to add SGLT2 inhibitors to her metformin. 3 months later, on follow-up visit, the patient was doing well. She had no more chest pains, no abdominal discomfort or bloating. Exercise tolerance test was performed and it was tolerated without anginal pain or ST segment changes. However, her fasting blood sugar remains high, 200 milligram per deciliter, and her hemoglobin A1C is still not controlled, although she was already receiving the metformin. So, in spite of having the two medications on board, her hemoglobin A1C was still high. So, instead, you stopped the SGLT2 inhibitor and you decided to add a TZD. But why TZDs? Well, TZDs are very good medications for lowering hemoglobin A1C and controlling diabetes, and we have very good experience with the medicine. But unfortunately, this group of medications has some cardiovascular safety concerns. They cause or exacerbate congestive heart failure in some patients, and that's why they are totally contraindicated in patients with symptoms of heart failure. And I have seen myself a few patients developing frank symptoms of heart failure with TZDs that completely resolved after stopping the treatment. Cardiovascular meta-analysis in 2007 just listing different effects on cardiovascular outcomes. Pioglitazone was associated with a significant 16% reduction in the 3-point MACE as a secondary endpoint versus placebo in a trial called the PROACTIVE trial. While rosiglitazone open-label data showed no increase in cardiovascular death, but there were concerns about sudden cardiac death, and there were concerns about admissions for heart failure. So the FDA reduced the safety restrictions on rosiglitazone imposed following the 2007 meta-analysis, but controversy over cardiovascular safety remains. And they stated that within the PPAR family, which are which TZDs belong to, there is no class effect, and each agent must be considered unique. The FDA has mandated that each agent within this class be evaluated individually in a variety of ways, including clinical outcomes trials. And I will show you the two mega trials done with TZDs. This is the rosiglitazone meta-analysis of patients, and you can clearly here see that when it comes to the MI and cardiovascular death, there has been a rather significant increase in the incidence of MI and cardiovascular death for those patients who received rosiglitazone compared to control. While on the other hand, the pioglitazone meta-analysis shows a favorable effect, almost a 19% reduction in MI and 8% reduction in the rate of death for those patients who received pioglitazone versus rosiglitazone. So there are no clinical trials directly comparing cardiovascular effects of pioglitazone and rosiglitazone, and that's why the effects has to be extrapolated based on the cardiovascular risk of the patient. So we added the TZD to the metformin, 2,000 milligram per day. The patient was doing very well. She reported no abdominal pain or bloating, no diarrhea, but there was no recent attacks of chest pain. On the following visit, her hemoglobin A1C was met with a hemoglobin A1C of 7.8%, which is less than 8. However, shortly after, hemoglobin A1C started creeping up again at 9.1, and her fasting blood sugar became again out of control at 215 milligram per deciliter. So the TZD was changed to a DPP4 inhibitor. Again, looking at DPP4 inhibitors, this is a very good and effective group of medications. We have saxagliptin, we have sitagliptin, we have linagliptin, and others. And all those medications were found to be safe in terms of cardiovascular mortality and morbidity. And the primary outcomes for all these medications were met during the trials. However, you have to know that these data is not a head-to-head comparison. When you look at the trials done for those medications, we have the SAVOR-TIMI 53 for Saxa, we have the Examine for alogliptin, and we have the TECOS for sitagliptin, and all of them has shown non-inferiority, no superiority, but non-inferiority, meaning that they are good enough. They do not cause harm, but we don't know if they will be or they will cause or benefit or protection to the cardiovascular system. However, when you look at hospitalization for heart failure, you see that there was a trend at statistically significant increase in the saxagliptin arm, non-statistically significant increase in the alogliptin arm, while sitagliptin was rather safe compared to placebo. So again, concerns regarding admissions for heart failure. So in spite of that, we added the DPP-4 inhibitor to her metformin. Hemoglobin A1C decreased again to 7.8. The patient reported no chest pain, no abdominal discomfort. Blood pressure was 130/84. However, 1.5 months later, hemoglobin A1C again increased to 8.3. So, and the patient started to develop recurring epigastric pain. Her GFR decreased to 71 ml per minute, lower than before, slightly lower than before. And at this point, they chose to add a sulfonylurea or to replace the DPP-4 with a sulfonylurea. Now, what about the cardiovascular safety of sulfonylurea? Well, going back to the UK PDS trial that was conducted over 20 years of follow-up, you will find that heart attacks were reduced by 22% in the sulfonylurea arm. Microvascular complications, especially retinopathy, were reduced by more than 34%, and any other complication was reduced by 18%. Again, you look at the clinical outcomes for any diabetes-related death or all-cause mortality, they were significantly reduced. Any diabetes-related endpoint or myocardial infarction or stroke, they were all reduced significantly compared to placebo in the arm of sulfonylurea. Now, when you look at the effectiveness of drugs added to metformin, especially if your hemoglobin A1C is sitting at 8%, you can see here that the greatest reduction in hemoglobin A1C occurs with insulin. And then with GLP-1 analogs, and the third is sulfonylurea, more than the DPP-4 inhibitors or any other agents. However, usually patients fail to achieve their target hemoglobin A1C in spite of all those medications. And going back to the studies on DPP-4 inhibitors and GLP-1 analogs, you can see here that, for example, the TECOS trial, 45% of the 15,000 patients were in sulfonylurea from 38 countries. In the SAVOR, 40% of the patients were on sulfonylurea. In the Examine, 46% of the patients were on sulfonylurea. In the EMPA-REG, 48% of the 7,000 patients were on sulfonylurea. And in the CANVAS, 43% of the patients were on sulfonylurea. And finally, in the DECLARE outcome trial, 43% of the 17,000 patients were in sulfonylurea. So this tells you that sulfonylurea was one of the main medications those patients were receiving before the addition of the trial drug. Again, looking at the GLP-1 analogs in the leader, 60% of the patients were on sulfonylurea, and in the sustain, almost 50% of the patients were on sulfonylurea. So the conclusion is 1 out of 2 patients were currently treated with sulfonylurea when these trials were published, and in 2019, the statistics revealed that almost 50% of the patients were receiving sulfonylureas worldwide. So we have so many medications and so many interventions to lower the blood sugar. But do newer agents lead to better control and improved safety? Well, let's look quickly. You see here that the prescription trends in the United States have changed between 2006 up to 2013. You can see that there is an increase in the prescriptions of metformin, a slight reduction in the prescription of sulfonylureas, a great reduction in the prescription of TZDs, a slight increase in the prescription of insulin, and a great increase in the prescription of DPP-4 inhibitors. And the reason behind that were concerns about glycemic control and hypoglycemia risks. But in spite of these changing trends, you will notice in this diagram that the hemoglobin A1C levels of control are actually being reduced. You see here between 2006 2013, less patients were able to achieve a target hemoglobin A1C of 6 to 7. And patients with hemoglobin A1C more than 9 increased from 9.9% to 12.9%. So the control of blood sugar, in spite of all the advancement in the management, did not reflect properly with the use of medications. So therapy changes are not translated into better control. Sulfonylureas are proved and they are still a valuable option after metformin. The current international guidelines have maintained sulfonylurea at the core of type 2 diabetes management with an early place in therapeutic algorithms and acknowledge that sulfonylureas are effective blood glucose lowering agents. They maintain the glycemic control at around 6.5 for 6 years. Sulfonylureas also offer the advantage of ease of administration, good tolerability, and low cost. And this meta-analysis that was recently published show you all the studies that have been conducted in terms of safety of use of sulfonylurea in safety in terms of cardiovascular effect. And the association between sulfonylurea use and the all-cause mortality and cardiovascular mortality in this meta-analysis revealed that sulfonylurea were not associated with increased risk of all-cause mortality, cardiovascular mortality, myocardial infarction, or stroke. And the current evidence supports the safety of sulfonylureas. An absolute risk of 0.5% could be firmly discarded. Another important issue to be taken into consideration when prescribing medications is financial issues. As you can see here worldwide, $1 out of each $9 spent around the world is spent on diabetes. And that is because the number of diabetic patients is increasing. And most of those patients are living in low and middle income countries. And that is why the medications prescribed to those patients should be affordable. And this publication tells you that for most patients with type 2 diabetes that is independently controlled with metformin, inadequately controlled with metformin monotherapy, the addition of sulfonylurea represents the most cost-effective second line of therapy. The use of sulfonylurea as a second line for type 2 diabetes generated glycemic control and quality of life comparable with those associated with other agents, but at a lower cost. And this algorithm tells you the recommendation of the ADA in 2019 for those patients where cost is a major issue. So those patients without established atherosclerotic cardiovascular disease or chronic kidney disease, the cost is a major issue. You start with sulfonylureas or TZDs. If the hemoglobin A1C is above the target, then you add the TZD to the sulfonylurea, or you add the sulfonylurea to the TZD. And if the hemoglobin A1C is still above target, you may consider the lowest acquisition cost of basal insulin or DPP-4 inhibitors or SGLT2 inhibitors with the lowest acquisition cost. Again, the International Diabetic Foundation treatment algorithm advises for the use of sulfonylurea as the first line of treatment sometimes, and usually puts it at a second line of treatment after metformin and basal, followed by basal insulin or premix insulin, especially when cost is a concern. Again, looking at another algorithm, you can see here that metformin sits at number 1 and sulfonylurea sits at number 2 in the Australian guidelines for the management of diabetes mellitus. And we have over 50 years of experience with sulfonylureas being safe and being effective in the management of diabetes mellitus, while the experience with any other medications does not exceed 15 years. So going back to the guidelines, as you can see here, metformin is number 1. And then depending on the risk stratification of your patient, you decide on the second and third, and if needed, the fourth line of management based on your hemoglobin A1C target. When you have concerns, you look at the side effects for medications. You see that metformin is being one of the safest medications to be used. However, for sulfonylurea, the biggest concern is usually hypoglycemia, while for TZD, it's edema and heart failure. For DPP-4 inhibitors, usually the side effects are very rare. For SGLT2 inhibitors, it's the gastrointestinal and dehydration. For genitourinary and dehydration. For GLP-1 analogs, it's the GI complications, and for insulin, of course, is hypoglycemia. And that is why you have to base your selection on the patient requirements. Remember that heart failure is more common in TZDs. DKA and amputations are more common in SGLT2 inhibitors, and thyroid C-cell tumors are more common with the GLP-1 analogs. But how to avoid hypoglycemia with sulfonylurea? Well, by unique designs. And this medicine, which is a combination between metformin and glibenclamide, is an example of the combination of a sulfonylurea with metformin that can really help in controlling blood sugar, since the soluble matrix of the tablet is metformin, and then the glibenclamide is available inside the tablet in a different particle spectrum. So each spectrum is released at a specific time in the blood, so it helps in the prolonged control of the blood sugar and avoiding hypoglycemia. And there are other contributing factors to hypoglycemia, and those include age, more than 70 years, polypharmacy, renal insufficiency, heart failure, dementia, and of course, malignancies. And that is why when you choose a medicine for your patient, again, you should tailor it according to the patient needs and profile. And why do we avoid hypoglycemia? Well, because hypoglycemia promotes endothelial dysfunction that can lead or can reduce vasodilatation. It increases the sympathetic drive, so it increases the blood pressure and the heart rate. It has an effect on increasing inflammation and increasing factor 7, which can also increase coagulation. And that is why we try to avoid hypoglycemia, because most of the cardiovascular recorded events were related to hypoglycemia. Now, I have to remind you in a conclusion that the patient center management is the core management now in diabetes mellitus. And this should be a multidisciplinary approach of the patient. And multidisciplinary approach should allow the patient to have specific or to check the patient's specific characteristics and consider specific factors that might impact the choice of your treatment. You should share the decision making and the management plan with the patient, and the patient should agree for his management plan. Once he agrees, you should implement it, and then ongoing monitoring and support of the patient, and then continuously review and agree on the management plan. And lastly, I will leave you with this slide. This is just an example of things that can keep you, entertained while you are staying at home, keeping yourself and others safe and staying out of trouble. With this, I conclude and I open the floor for questions. Thank you very much for your attendance. Okay, the first question is, it seems that people is more concerned about her cardiac condition than her diabetes. Well, what are the investigations done to identify the cause of her chest pain? Well, I know that I'm a cardiologist, but anyway, this patient should have had an ECG, an echocardiography, and a stress test. And actually, she underwent a stress test at a certain stage of her disease or her follow-up, and her stress test was negative and her chest pain subsided. Well, the second question is also a very nice question. For using in weight reduction, how to adjust the dose? Well, you have to know that metformin is not mainly or is not indicated mainly for weight reduction. People use it to reduce the weight, but we do not, it's not advisable, and I don't think it's even in the insert leaflet of the medicine that it should be used for weight reduction. So those who are using the medicine for weight reduction should be very careful, and they should have a quick check of their, especially kidney functions, before they decide to take the medicine. Now, the dose usually you start with, again, I shouldn't say that, but again, this is not based on any trials. This is only based on experience and thoughts that we got from our colleagues. They usually start by 500 milligrams twice or three times a day based on the tolerance, because we know that metformin has some gastrointestinal side effects. Now, if it is well tolerated and achieving a reduction of weight of around 5 to 7% over a period of 1 to 2 months, then it's advisable not to increase the dose. And if the weight is not being reduced, then you might consider shifting to a higher dose, which is 1,000 twice daily. But again, I have to remind each one that those medications are not for weight reduction. The third question is, why not GLP-1 inhibitor in the list after metformin, or even after as patient already has a high cardiovascular risk? Excellent question. But I have to go back and remind you that at the beginning of the case, maybe you did not join or you joined later. At the beginning of the case, we said that the patient did not want any injectables. And unfortunately, all the available GLP-1 analogs to date available in the kingdom are injectables. Soon, we will be having the first oral GLP-1 analog in the market. But until then, and because the patient does not want any injectables, that is why it was not chosen at the beginning, or it was not among the choices for her management. But I definitely agree with you that since she is a high cardiovascular risk, GLP-1 analogs should be considered. But here we have to respect the patient preference and the management plan that was decided with the patient. Another question, why not triple than long time, two different drugs? Another excellent question. Well, you need to wait and see how your hemoglobin A1C changes. And the problem with the hemoglobin A1C is it changes over at least 8 weeks and above. So you don't want to modify a medicine that might be effective and tolerated by the patient without an evidence that it did not work. And that's why you give the medicine and then you repeat your hemoglobin A1C. And if the patient is not reaching the target, you decide either to add another medicine or to change it to something else. Now, the second concern was that she doesn't want a polypharmacy and that she's trying to minimize the tablets or the number of tablets she is receiving. And that is why we were switching between one group to the other. Now, another plan could be using 3 medications at the same time, or from the second stage or the second step or the second follow-up. But according to the guidelines, you should go stepwise, adding one medicine at a time. Well, it seems these are the questions I received so far. However, if you have more questions or if you have any concerns, I think that the following sessions we will have eminent speakers and they can address your questions at a later stage. However, for this time, since we don't have further questions, I would like to thank you all for your attendance. I would advise you to stay home, stay safe, keep yourself safe and keep others safe. Avoid unnecessary travel, unnecessary leaving the house. And if you leave the house, then try to respect social distancing much as you can, and always use a face cover when you go outside. Thank you very much again for attending, and hope to see you again in another webinar. Bye-bye. Stay safe.